Hello, my name is Elena Arbelo. I work in Hospital Clínic de Barcelona. I have been a member of the 2020 ESC guidelines for the diagnosis and management of atrial fibrillation, and I'm really happy to be here today to share with you a presentation on quality of AF management, outcome measures, and patient-reported outcomes. These are my disclosures. And to set the frame of my presentation, I will begin sharing with you the definition of quality of care by the World Health Organization. Quality of care is the extent to which healthcare services provided to individuals and patient populations improve desired health outcomes. In order to achieve this, healthcare must be safe, effective, timely, efficient, equitable, and people-centered. The concept of improving desired health outcomes is something that I want to highlight because it's the ultimate aim of what we do. Outcomes in atrial fibrillation include a wide list, including what we consider the hard outcomes, like mortality, stroke, heart failure, or hospitalization, but also others that are traditionally considered or underestimated, like cognitive decline, depression, impaired quality of life due to symptoms or other factors like treatment, side effects, or coping with the disease. This slide and probably the next one you have seen already in the previous presentations, and basically summarize what the current guidelines recommend for the management of atrial fibrillation. First, we must confirm atrial fibrillation. Secondly, we have to characterize atrial fibrillation, and for that the 4SAF scheme aims at promoting structure characterization of atrial fibrillation, including stroke risk evaluation, symptom severity, as assessed by the ERA score or quality of life questionnaires, the severity of AF burden, that is, the AF pattern and the total time in AF, and the severity of the substrate, including the presence of risk factors and comorbidities and markers of atrial cardiomyopathy as enlargement, dysfunction, and fibrosis. The ABC pathway summarizes the three treatment pillars to consider when treating a patient with atrial fibrillation. The first is to evaluate the need of anticoagulation. The second is the need to improve symptoms in these patients, and this includes several aspects, including optimizing rate control and considering the need of rhythm control strategies like cardioversion, antiarrhythmic drugs, and ablation. Finally, the third pillar covers the need to evaluate comorbidity and risk factors and manage them. Several international registries have found that the adherence to guideline-recommended therapies in the treatment of atrial fibrillation is associated to improved outcomes. In the figure, you can see the findings of the pilot phase of the AF General Pilot Registry. Regarding the antithrombotic therapy, under-treatment or over-treatment is associated with worse outcomes in terms of a composite of cardiovascular death, thromboembolic events, and bleeding, and the presence of any thromboembolic event. Therefore, the current guidelines recommend the systematic collection of quality indicators to evaluate areas where treatment can be improved. As described by Avidius Donavedian, founder of the study of quality of care and outcomes research, to evaluate quality in healthcare, there are three main areas that we need to consider. First, structure. That is, whether the available resources are adequate in terms of quantity and quality. Second, the process, which includes both technical aspects and the interpersonal care. And third, the outcomes, which may include different markers of health, including user evaluation and also experience and patient-centered outcomes. The rationale behind this is simple. We consider that if we provide or we have the proper settings and instrumentalities, good medicine will happen, which is process, and if good medicine happens, outcomes will also improve. With this in mind, a task force was set, composed of 23 people from 12 different countries to create a set of quality indicators to allow proper measurement of quality of care in the management of AF. This task force included 11 members of the ESC and the European Heart Rhythm Society, 8 of which were members of the task force of the guidelines, 2 members of the Asian Pacific Heart Rhythm Association, 2 members of the Heart Rhythm Society, 2 members of the Latin American Heart Rhythm Society, and finally also 4 patient representatives, 2 of which were members of the ESC patient forums, and 2 others were representatives from major arrhythmia and atrial fibrillation patient associations. It is hoped that the developed set of QIs can be used to spread a wide assessment of quality of care in atrial fibrillation and promote improvement initiatives in this area. The methodology we used was composed of 4 different phases. The first step was to develop an initial extensive list of quality indicators based on a systematic review and review of all the clinical guidelines and any paper related to quality indicators in atrial fibrillation. The second phase, we reviewed the list of extracted indicators from the systematic review and the clinical guideline review, and we distributed it among the 23 members of the task force to assess whether we have missed any major quality indicator to include. There was a particular sub-task force for PROMs, for patients' reported outcomes, composed of experts in outcomes evaluation and also the 4 patient representatives, and also a particular subset who evaluated the 2020 ESC guidelines to ensure alignment of the proposed QRs. With this, we came out with a very extensive list of quality indicators and outcome measures. And then in the third phase, what we did was select, using a Delphi round or Delphi evaluation, the indicators to be included in the final list. The requirement was that there was at least a 75% consensus whether to include or not to include a particular indicator, and specific indications were given in regards to the characteristics of a good quality indicator. This included the importance, the evidence base, the specification, validity, reliability, feasibility, interpretability, and actionability. All these qualities are recommended by the methodology paper from the ESC on how to select quality indicators in cardiovascular disease. Finally, there was external validation phase where we had external reviewers from 4 different heart rhythm societies. This includes the European Heart Rhythm Society and the 3 other sister societies, which represented 11 external reviewers of our document. So this figure summarizes the overall result of the systematic review. In the end, we had over 400 indicators from which the Delphi rounds were based upon. And this summarizes the final selection of quality indicators in our effort. There were 5 main QIs, which are represented in this figure, and 17 secondary QIs that you will need to access the paper published in Europe simultaneously with the ESC guidelines to see. Basically, what we did is we grouped the different areas of treatment in atrial fibrillation into 5 domains, and we added a 6th domain, which was outcomes, and it is placed in the centers to highlight the importance of managing and evaluating the quality of care of all the other 5 domains in order to improve the 6th domain, which is outcome. Now we will review briefly the main outcomes for each of the 6 domains. The first domain is patient assessment. In this group, you see the summary that it's published in the guideline document. We had 3 main quality indicators. These were the evaluation of stroke risk, the evaluation of bleeding risk, and a third one, which is not listed in the guidelines because it's a summary, is the measurement of the serum creatinine, because this will be needed for an appropriate management of antiarrhythmic anticoagulation treatment. The second domain was anticoagulation, and there we included three main quality indicators. The two first ones are related to appropriateness of indication of anticoagulation. So the first one was to ensure or to measure inappropriate prescription in low-risk patients, and the second was to evaluate proper prescription of anticoagulation in high-risk patients. And it is described in the table, and you can access it also in the guidelines and the position paper on quality indicators. There was a third main quality indicators, which is not included in the guidelines, but we added this third one to evaluate the quality of anticoagulation by using the TTR for vitamin K antagonist and appropriate dosage for NOACs. The third domain was rate control, and only one main quality indicator was included. This was the inappropriate prescription of antiarrhythmic drugs in patients where no sinus rhythm attempt to restore sinus rhythm is made. The fourth domain is rhythm control, and here we had three main quality indicators. First, it was the prescription of antiarrhythmic drugs in patients with structural heart disease. The second was the proportion of patients in whom ablation was offered after failed or intolerance to antiarrhythmic drugs, class 1 or class 3. And the fifth domain was the risk factor management. It was deemed that it was important not only to identify the modifiable risk factor, but also to take measures to improve them. However, for actionability and practical reasons, it was difficult to implement for each of the risk factors. Therefore, what we attempt to measure with this quality indicator is whether risk factors have been identified and tackled as our overall. And finally, and I here present the list of outcomes that we included in the full paper. In the guidelines you will see a summary of them, but here I wanted to highlight all of the outcomes because this is what we ultimately we want to improve, and because you will see that we have separated them into three main areas. The first main area is what we consider consequences of the disease. These are all-cause mortality, these are embolic events like ischemic stroke and transient ischemic attack. These are also consequences of treatment, like bleeding events, procedure-related mortality, procedure-related major complication, or drug-related serious adverse events. And finally, there's a third group, which is patient-reported outcomes, patient-centered outcomes, which includes one main quality indicator, which is measuring health-related quality of life, but there are other four that are relevant prompts that have been also included, but there was not sufficient evidence base to recommend them or recommend their collection as a main indicator. Hopefully, and following the recommendation of the 2020 ESC guideline of systematic collection of patient-reported outcomes, in the future we will have sufficient evidence to not only include these as main quality indicators, but also to know which are the best tools to measure them. So with this, I would like to summarize my presentation into three main messages. Guideline compliant management has shown to improve outcomes in atrial fibrillation. Quality of care should be measured to identify opportunities for improvement and management and improving patient outcomes. And it is recommended to routinely collect patient-related outcomes to measure treatment success and to improve patient care. Thank you.
Professor Andrea Russo. I'm from Cooper Medical School of Rowan University in Camden, New Jersey in the United States, and I'm very pleased to present at the ESC Congress 2020, the Digital Experience. The title of my talk is When Should I Consider a Patient for Primary Prevention ICD? These are my disclosures. So we know that there's lots of global and regional variations in ICD usage based on different countries here in Europe, as well as within the United States. Some practices implant a lot of ICDs and others implant very few in those who meet criteria for primary prevention. So what is the data? So one of the very landmark trials was the sudden cardiac death and heart failure trial. This looked at patients with both ischemic and non-ischemic heart disease, an EF of 35% or less, with a median follow-up of 45 months. Patients were randomized to ICD versus amiodarone versus placebo, and there was a significant reduction in mortality in those who received an ICD. Similar pattern in both ischemic and non-ischemic patients. So here is a summary of all the different trials. The first ones were non-ischemic trials for primary prevention. Definite and Danish include just non-ischemic, and these two included both ischemic and non-ischemic. You can see that SCUD-HEF was the largest patient study. There were also, the longest follow-up was in Danish, followed by SCUD-HEF. You can see that ejection fractions were about 35% or less in most of the studies, with most patients having class 2 or 3 heart failure. If they had class 4 heart failure, they would get CRT devices. But what's most dramatic, you could see, is the medical therapy given in some of the earlier trials was not very good. Beta blockers, ACE and ARB usage, but very good later on in Danish. Overall mortality reduction was seen in 5 out of these 7 studies. So what do the guidelines say? Well, they tell us when to put an ICD in ischemic heart disease patients. These are the US guidelines: EF 35% or less, at least 40 days post-MI, and at least 90 days post-revascularization with class 2 or 3 heart failure. Class 1 heart failure, 30% or less EF indication for ICD. But if you have class 4 heart failure and you're not a candidate for transplant or CRT, that would not be recommended to implant an ICD. What about the European guidelines? Well, similar recommendations. However, the European guidelines do give us a duration of optimal medical therapy of 3 months or more, a time period of anywhere between 6 weeks in these guidelines and 40 days in the heart failure guidelines before putting an ICD in, that you should wait after an MI. So what data do we have early after MI? Well, there's 2 studies. The first one is Dynamite, that randomized patients who had an MI within 40 days to either ICD or medical therapy. No difference in overall mortality in that study. Many of these patients, however, did have revascularization, to keep that in mind. Similar in IRIS, again, no benefit of ICD therapy within 31 days of MI. Similar to Dynamite, this study also showed that many patients received revascularization. What about MADA-2? This was a post-hoc analysis of MADA-2. MADA-2 excluded patients who had revascularization within 3 months. And you can see that those between 3 and 6 months here, they did not have any benefit of ICD therapy when it was implanted that soon after revascularization, but did if it was implanted further out. What about, so there are lots of different scenarios for ICDs, not all of which are covered in the guidelines. And there's a document called the Appropriate Use Document in the United States. We're actually in the process of updating this right now that I'm co-chairing. But this particular document looks at different scenarios where there may be gaps in the guidelines and modifies it by diseases, different types of diseases, symptoms, results of non-invasive testing. And there's certain scenarios where, for example, maybe in certain situations like early after ICD, after revascularization, you might consider an ICD in a rare situation. For example, if a patient had revascularization, had maybe a concomitant valve, had complete heart blockage, had a long-standing cardiomyopathy, even though they were just revascularized, they're going to need a pacemaker, you may put an ICD in up front rather than waiting 3 months and bringing them back and upgrading them to an ICD later on. So what about the non-ischemics? Well, these patients with non-ischemic heart disease have class 2 or 3 heart failure, EF of 35% or less, as in SCUD-HEFT, and ICD is recommended. If that persists despite guideline-directed medical therapy with a high level of recommendation, a little lower level of recommendation 2B if it's class 1 symptoms in non-ischemic patients. Similar recommendations in the European guidelines with the exception of just a little lower level of evidence for the non-ischemics. So what about the Danish trial? So this is a trial that kind of changed a lot of things for us, and the way we looked at things. This study randomized patients to ICDs versus usual clinical care if they had an ejection fraction of 35% or less and class 2 to 4 heart failure. If you had class 4 heart failure, you had to receive a CRT device. Overall, these were relatively stable outpatients who were on guideline-directed medical therapy for a while, and you could see here that the outcome was not any better with an ICD in this population of non-ischemic patients. In addition, you could see how well, as I pointed out earlier, how great the background medical therapy was. In addition, 58% of these patients also had CRT devices in place. So what about the different age groups? If you look at all-cause mortality in Danish by age, you can see that the younger patients actually in this post-hoc analysis, younger patients actually did benefit from ICD therapy, whereas over 70, there was no benefit of ICD therapy. And then if you look at how patients died, there was an excess of non-cardiac death in patients who are over 70, which you might expect because older patients are more likely to have other comorbidities. So we're looking at competing risks. So what do we do? So sometimes we could even consider using risk models. And this is one risk model, the Seattle heart failure model, looks at a scoring system to predict all-cause mortality. And it does very well in predicting that. And then there's also a proportional risk model that uses measures to identify patients who are more at risk of sudden death, because those are the patients who may benefit most from ICDs. But right now, most of our trials have really just looked at ejection fraction as the major risk stratifier. But there's other clinical factors that can be looked at. In addition, ECG variables, echo findings, and then late gadolinium enhancement by a CMR is something that's very promising, looking at the presence of myocardial fibrosis and the substrate itself in predicting sudden death risk that might help you identify patients who are most likely to benefit from ICDs. In addition, serum biomarkers have been looked at, but this really just correlates more with an increased risk for total mortality as opposed to specific for sudden arrhythmic death or arrhythmic events. This is just one study looking at non-ischemics, although similar findings are seen with ischemic disease patients, 472 patients with dilated non-ischemic cardiomyopathy. And you can see that fibrosis is mid-wall in these patients. Overall, even after adjusting for left ventricular ejection fraction and other prognostic factors, the presence of fibrosis and the extent of fibrosis was independently associated with all-cause mortality as well as sudden cardiac death mortality. So this provides excellent additional independent prognostic information. So in conclusion, although randomized trials have shown an overall mortality benefit of prophylactic devices in people with reduced LV function, studies have questioned the effectiveness of ICDs in certain subgroups. Most consistently, ICDs improve outcomes in those with ischemic disease who are at least 40 days post-MI and even longer after revascularization. The role of ICDs in those with non-ischemic cardiomyopathy, though, has been questioned, particularly with more advancements in guideline-directed medical therapy that's being utilized with the appropriate duration and the appropriate dose, or even when you combine it with CRT, because that can help with remodeling and improve outcomes. And to make it even more complicated, non-ischemic cardiomyopathy patients are really not a single disease. It's not a homogeneous population. There's various etiologies of cardiomyopathy. So the current guidelines base selection of patients on clinical enrollment criteria, but we need better risk stratification methods to improve identifying those patients who are at risk of arrhythmic death rather than just all-cause mortality to help us better maximize the benefit of ICDs. Thank you. Thank you for joining, and thank you for inviting me.
Hello, everybody. I'm Wilfried Mullens from Genk, Belgium, and it's a pleasure and honor to present during the digital experience of ESC to talk on CRT, which heart failure patients should receive CRT, and how should they be followed. I'm a heart failure specialist who does actively implant CRT devices, and I'll try to explain to you how you can integrate CRT into your own practice. The guidelines with regards to CRT indication did not change the last 5 years. CRT is a class 1 recommended therapy in HFrEF patients with a wide QRS, left bundle branch block morphology, who are on optical medical therapy but still having symptoms of heart failure. What did change, however, is stipulated in this clinical practice update, which HFA published a couple of months ago. And there we stipulated that the benefit of ICD is determined by the risk of sudden cardiac death over the risk of non-sudden cardiac death. It's important that you incorporate a high comorbidity burden of the heart failure patients. High comorbidities mean less likelihood that the ICD will be of benefit. Also, if you have to think that the rate of sudden cardiac death is decreasing because better background medical therapy. It's up to 1% per year in a primary prevention population. That's the reason why we need more trials that can compare CRT-P versus CRT-D, like the ongoing RESET CRT trial. Why do we need to think of CRT in 2020? Well, first of all, 30% of our HFrEF patients have a wide QRS. If they have a wide QRS, their prognosis is worse. The wider the QRS, the worse the prognosis is. The only therapy that can do something about that wide QRS is CRT. CRT actually leads to positive reverse remodeling. You see an improvement in ejection fraction, a reduction in volume with every single trial that looked at echo after CRT. Importantly, if you see an improvement in ejection fraction, a reduction in volume, that leads to an improvement in outcome. Remodeling has a very strong prognostic impact on outcome. How many of these devices are we implanting? Well, about 170 per million inhabitants per year in Europe. 2/3 are CRT-D, 1/3 is CRT-P. However, we have to bear in mind that if you would implant according to the guidelines for a class 1 and 2A recommendation, we should be implanting 400 CRTs per million inhabitants per year and not 150. That means that the most frequent reason for no response is a no implant, and we should do something to overcome the underutilization of CRT. We are implanting sick patients. They have high ages, a lot of them have ischemic cardiomyopathy with very high comorbidities. They have high NT-proBNPs, very dilated ventricles. These are not the patients that we expect to be cured from heart failure by a device therapy. This does not mean that you should not implant. It just means that expectation is not that these patients will be cured from CRT. And therefore, there are a lot of untrue myths with regards to CRT. One of them, which I hear very frequently, is that ischemic cardiomyopathy patients do not benefit from CRT. This is absolutely not correct. In all the trials, CRT was as effective with regards to hard endpoints, heart failure hospitalization, mortality reduction in ischemics versus non-ischemics. This false myth comes from the fact that ischemic heart disease patients have less improvement in LV function. However, because they have a higher absolute risk for adverse outcomes, their relative risk reduction is similar. That means that a tiny bit of improvement in ejection fraction means the same as a larger improvement in ejection fraction in a non-ischemic cardiomyopathy patient population. So never deny CRT to a patient with ischemic cardiomyopathy if you feel that patient will not benefit, because you might be wrong. Another untrue myth is the fact that people believe that if patients did not do better after CRT, then that would mean that the device is not working. This is an elegant study we've performed about a decade ago where we turned off the CRT devices in patients admitted with advanced heart failure with a pulmonary artery catheter. And what you could see is very evident. They had a drop in systolic blood pressure, an increase in wedge pressure, and a decrease in cardiac output. So that means that patients do not appear to have benefited from CRT, often deteriorate when you withdraw therapy. CRT is therefore not a curative heart failure therapy, but it should be seen as a treatment to ameliorate dysynchrony, which will ultimately reduce heart failure-related morbidity and mortality. Look at CRT like oncologists look at their medical therapy. You can have patients who go to a full remission. You also have patients who go to partial remission. And it's our task as heart failure caregivers to ensure that we do everything we can to get the maximum out of every heart failure therapy that we have. How do you do that? How you can get most out of the device? Well, the traditional outdated concept is that the patient goes to see his cardiologist, his imager, his EP physician, rehabilitation physician. That does not work anymore in 2020. In 2020, it's time to embrace a new device specialist. And that new device specialist should look at all aspects of heart failure and device care. We should try to optimize the device settings, deal with arrhythmias, deal with anemia, deal with suboptimal medical therapy. And if we do that, then we surely can improve the outcome of a CRT recipient. How do we deal with the interpretation of the device analysis? Well, there are diagnostics, there are measurements, and there are programming. Diagnostics, for example, there's more than just battery longevity. There's a percentage of bi-V pacing, which should be 100%. There's a heart failure logarithmics, where you can look at heart rate variability, activity, lung impedance. All of these aspects can show us things that can help to treat these patients better. Look at arrhythmias, and then do your measurement and do your appropriate programming. The frequency program is important. The AV timings are important. The sensitivity and the Menteke settings, all of these things are very important if you want to try to improve the outcome. Do we do a good job? No, we don't. This is real life data, 80,000 patients. 40% of them did not receive 100% bi-V pacing, often because of arrhythmias or inappropriate timing of the AV. Appropriate AV timing leads to a dissociation of the E and A wave, but will not interrupt the end of the A wave. In 60% of the times, you have it right with out-of-the-box settings, AV timings 120. However, often this is not the case. Then you should do something to try to improve that, either by echo or by EKG-guided optimization strategies. Atrial pacing, is that important? Yes, less is more. Why? Just like we have a PV loop, we also have a PA loop. And you don't want to disturb this PA loop, because if you disturb the PA loop, we have more atrial fibrillation, more mitral regurgitation, less reverse remodeling in the ventricle, and worse outcomes. So it's better to program a lower basal rate than a higher basal rate in order to avoid atrial pacing. Of course, we have to appropriate program the VT zones, try to avoid inappropriate shocks, try to use ATP instead of a shock in the lower VT zone. How do you do all of that? Well, HFA, ERA, and ESCVI are about to publish this document where we actually explain how you should do this. After the implantation, you do an EKG to ensure bi-V pacing, a chest X-ray to ensure appropriate lead position, and you come up with a disease management plan straight after the placement of the device. This needs to be done straight after the placement. After 3 months, you do an echo and an EKG device analysis, and you also do an exercise test to ensure you have bi-V pacing during higher heart rates. Again, you look at medical therapy and try to optimize the heart failure medical therapy. And then every year, you have to do the same exams again, and you have to consult different subspecialties if the patient would need it, either EP, palliative care, interventional cardiology, depending on the status of the heart failure patient. So, to conclude, ladies and gentlemen, 4 important concepts in CRT. First of all, we don't want to talk about anymore about responders. We call it disease modification. We have to deal with under-implantation of the device therapy. We shouldn't wait too long before we refer patients for CRT, because wide QRS will not be cured with medical therapy, and we should optimize heart failure in the CRT patient. All of that will be published in this document, hopefully soon, by European Journal of Heart Failure, together with Europace later this fall. Thank you for your attention.
Good morning. My name is Mauro Biffi from Bologna University Hospital in Italy. I welcome you all to this focus on the management of patients with clinically significant bradycardia. This might conflict your interest. Pacemaker therapy has evolved in history from supporting against asystole to functional improvement of the patient. In this way, pacing therapy can prevent the new onset of heart failure and atrial fibrillation, the main summarized here, underline the role of AV synchronous pacing versus single-chamber ventricular stimulation that is deserved to those patients who are in AF as predominant atrial rhythm, or who need stimulation only seldom for recurrent rare asystole, or for those patients who are clinically heavily compromised. The guidelines also suggest to consider CRT for those patients who, with the left ventricular systolic dysfunction, namely an ejection fraction between 35 and 50%. This accent on AV synchronous pacing is put forth despite any evidence of the mortality benefit of AV synchronous versus single-chamber ventricular stimulation. But the clinical perception is that heart failure and atrial fibrillation are importantly reduced by AV synchronous pacing, and that stem out of observation in the major 4 trials comparing these 2 strategies that detected a 20 to 30% crossover of VVI versus DDD. The onset of such unwanted clinical outcomes was mainly based on patient selection bias and heterogeneity in the main trials. We learned from these trials that AV synchronous pacing is more effective the more ventricular stimulation is delivered. But anyway, left ventricular function is disrupted by right ventricular stimulation that causes uneven and desynchronous ventricular activation and contraction. We also learned that despite being AV synchronous, a DDD pacemaker can be hemodynamically identical to a single-chamber ventricular unit under certain circumstances that prevent the appropriate left ventricular preload. And these are a too short AV interval, just like with untailored AV interval during atrial pacing, or when a too long AV interval is observed, just like in the case of the RV pacing minimization strategy, that should be anyway adopted to prevent the unwanted effect of right ventricular stimulation. Here you see no left ventricular preload. So that makes clear what are the physiological drivers of future developments in cardiac pacing. We shall be able to restore a physiological ventricular activation that does not disrupt left ventricular mechanics and enables a normal left ventricular preload. In this way, we have to find a suitable solution for different clinical scenarios. LBDD patients may have a reasonable solution in terms of restoration of physiological activation by CRT or by ventricular stimulation. Whereas those patients with a strictly normal QRS and AV block or AV block and an LBDD pattern may have a missed potential to restore physiologic contraction. And this is what we desire: atrioventricular and ventricular-ventricular coupling. This is the place where conduction system pacing comes in. It can correct any AV conduction disturbance arising between the AV node and the branch's bifurcation. There are two types of conduction system pacing in the His bundle level. That is non-selective, where the recruitment of fibers for the left bundle and right bundle occurs at the same time with septal activation, and a selective His bundle pacing where only excitation of conductive fibers to the LB and the RB is delivered. This latter scenario is depicted here, where you see complete AV block plus incomplete left bundle branch block being corrected by His pacing that elicits a QRS identical to a normally conducted beat in the native His Purkinje network. It makes sense that this restores physiologic AV coupling and ventricular activation, and was proven to be clinically helpful in these observational registries from the Geisinger Institution, where His bundle pacing proved superior to conventional RV pacing in reducing heart failure hospitalization and upgrades to biventricular stimulation. Noteworthy in this registry, it was not observed a significant difference between selective His bundle pacing and non-selective His bundle pacing. Matter of factly, recently, left bundle pacing by screwing lead in the interventricular septum to reach the left bundle has proved as beneficial as CRT in patients who are candidates to CRT, and could be dreamt of as a possible solution also for patients with complete AV block below the His bundle level. Though brilliant, conduction system pacing suffers some substantial limitation. Clinical efficacy is based only on observational studies. It is technologically challenging and requires a high expertise to be implemented. And only now, appropriate delivery systems and dedicated pulse generators are under development across all manufacturers, technology being unsatisfactory in the majority of centers to achieve an appropriate selective His bundle pacing or left bundle pacing. Of course, there are concerns about the long-term stability of the pacing threshold and the evolution of the conduction disorder below the His bundle. Anyway, it has found a place as His bundle stimulation in those patients who have a block at the nodal level with a depressed ejection fraction in the range 35-50%, and as a blatant pace strategy for supraventricular tachyarrhythmias. On the other side stands our unmet need to minimize the complication related to leads and to device surgery. That's where leadless stimulation has entered clinical practice. Beyond patient in AF, or those who have only seldom need of cardiac stimulation, it uniquely suits the most challenging patients, those who have superior access issues to the heart, or who need to preserve the main thoracic vein for the access to the heart for any reason. Those patients frailer in terms of exposition to device surgery, pocket and infection issues, and those patients who already had a device complication. Given the battery size, leadless pacers are heavily impacted in terms of longevity by any increase in the pacing threshold and cannot provide extensive clinical diagnostic or patient mentoring. Its physiological competitor, that is a single chamber unit, very cheap, connected to a His bundle lead, requires a more challenging technical implementation. Only recently, AV synchronous pacing via a single chamber leadless unit has entered clinical practice. It is fascinating that the P wave is detected as a mechanical event by the built-in accelerometer, and it is tracked to the ventricle when the heart rate changes. As you can see, sinus rate is more physiologic than the sensor indicated rate, sinus rate being this one, and it can be tracked reasonably well, though some underperformance is observed during exercise when the sinus rate increases above 100 beats per minute. Though ventricular activation resembles the conventional RD stimulation pattern, this may probably suit the majority of the elderly patient with AV block by enabling a fair amount of synchronous AV pacing, although far different from a normal DGT unit. When approaching the future of cardiac pacing, we will have to acknowledge that we need to trade off some of the main outcomes in pacing therapy. That is the individualized patient outcome, the complexity of the implantation procedure for its broad applicability, and the sustainability of therapy. So it is time that we plan appropriate control studies based on the outcome to compare conventional and emerging new technologies so that we can reach a patient-tailored decision making towards a less is more or a more is more therapeutic decision. Thank you for your attention.
Ok, ¿algún comentario, residentes? Al final creo que, empezamos a ver dos pláticas, ¿no? Sobre más cosas electrofisiológicas, no electrofisiológicas, ¿no? Sino resincronización y estimulación de las de His y los leadless pacemaker. ¿Algún comentario?
Hola, doctor. Sí, no sé si recuerdan la vez que nos llevaban a la plática de resincronización cardíaca, donde tocábamos el tema exactamente de la estimulación hisiana, que tiene los beneficios de que solo se necesita pues prácticamente un cable que puedes estimularlo para, en caso que el paciente tenga bloqueos, y que en determinados pacientes con las ciertas características podría hacer hasta una resincronización de acuerdo a tú cómo estimules el haz de His para la contracción ventricular. Entonces, es una terapia que se ha venido posicionando en los últimos años como, pues ya, yo creo que ya no ni emergente, sino ya como toda una realidad de la estimulación hisiana, menos invasiva para el paciente, no requiere de tantos cables como sabemos con el dispositivo de resincronización. Entonces es una buena opción que hay que tener en mente para nuestros pacientes que sean candidatos a la misma.
Sí, perfecto. En cuanto a resincronización, las cosas importantes que mencionó el ponente es ¿cómo se llama? Que a pesar de que vayan mejorando los pacientes, desremodelándose, oyéndose una remodelación positiva, el tratamiento de la insuficiencia cardíaca tiene que continuar, ¿no? Sí, es muy importante.
Creo que por ahí hay unos criterios para como que el paciente ideal para resincronizar. No me acuerdo ahorita del nombre de los criterios, pero como ya hemos visto en las guías, el QRS en hombres es arriba de 140, en mujeres 130, que la morfología en B1 y B2 tiene que tener morfología de QS o R minúscula, S mayúscula, que tengan como un notching en el complejo QRS, en las derivaciones B5, B6. Esos son como criterios electrocardiográficos para el paciente ideal a resincronizar. Ya no solo va en cuanto a la duración del QRS, sino también en cuanto a la morfología del complejo.
Perfecto. Ok. Muy bien. A ver, Ricardo, ¿terminaste tus diapositivas? ¿Las tienes por ahí?
Sí, doctor.
A ver, rápido. Tienes 3 minutos para tu clase magistral. Poncho, ¿te comunicaste con el doctor Carrillo?
No, doctor, no me he comunicado todavía con él. De hecho, me acaba de decir Eric hace ratito que quedó programado el paciente marcapasos, que la prueba de este Neftalí todavía no salió, entonces que hasta que salga se programa la coro. Pero
Perfecto.
ahorita le hablo al doctor Carrillo
A
para
ver qué
ponernos de
requiere
acuerdo
y todo
de...
eso, ¿no?
Sí,
Sí, preséntale al paciente, etcétera, etcétera.
ok, doctor.
Ok,
Yo ahorita le
adelante,
marco.
Ricardo. Este es Jacobo.
Sí, tomé las imágenes del propio paciente, las grabé ahí del equipo, no se ven muy bien. Entonces vamos a ver los pasos necesarios para cuantificar el PISA en una insuficiencia mitral. Vamos a ver así de rápido. Estos pasos los tomé de la Sociedad Española de Imagen. Son, digamos, tiene una página de internet que voy a poner al final, donde pues tienen así como pasos muy prácticos para la valoración de múltiples patologías cardíacas. Entonces, primero, optimizar la imagen en 2D. Esto pues, se refiere a obtener la mejor imagen de manera que podamos valorar la morfología del aparato valvular y determinar si es primario y secundaria, porque los parámetros que vamos a ver son diferentes si la enfermedad valvular es primaria o secundaria. Entonces aquí con este paciente sabemos que la miocardiopatía dilatada es la que finalmente está generando la insuficiencia mitral. No parece haber un daño valvular intrínseco. Entonces, a eso se refiere con obtener la imagen en 2D. Eh, Hay que optimizar la ventana para ver el Doppler color. Tenemos que ver el Y de regurgitación, si es excéntrico o si es central. También esto tiene que ver con el origen de la insuficiencia, si es secundaria o es primaria. Entonces, aquí es un Y más bien excéntrico que se va por la pared de la aurícula, generando el fenómeno de Coanda que ya conocemos. Entonces tenemos que ver eso porque nos tenemos que alinear bien con el jet de regurgitación. Una alineación más allá de 20 grados ya no nos da parámetros valorables objetivamente. Entonces es lo que tenemos que ver. Después hay que aplicar el zoom color en plano apical de 4 cámaras de la válvula mitral. Es lo que estamos haciendo, ya nos posicionamos, aplicamos el zoom y esto nos va a servir para ver ya aquí algunos parámetros. Con la imagen previa, ya vemos más o menos el tamaño del jet, el porcentaje que ocupa dentro de la aurícula y aquí es para ir midiendo los parámetros que nos van a servir del orificio regurgitante. Vamos a desplazar la línea de base de la escala de color en la dirección del jet de regurgitación. Aquí, bueno, no os puse una imagen, pero pues la imagen sería, pues esta es la línea, la tenemos que desplazar y que esté alineada con el jet de regurgitación. Es algo que ya hicimos. Y una vez con el zoom, vamos a empezar a hacer las mediciones. Aquí, lo que vamos a medir es el máximo radio de PISA. El radio PISA, bueno, aquí es una parte del flujo o del jet de regurgitación. Aquí el flujo se acelera en dirección al orificio de regurgitación y se forman capas concéntricas de isovelocidad. Por eso es el PISA, que es el área de isovelocidad, del área de isovelocidad proximal. Entonces, de manera que si conocemos la distancia o el radio de este orificio, que es una hemisfera, si conocemos el radio y la velocidad de flujo en este punto, se puede calcular de forma indirecta la masa de sangre que pasa por esta capa virtual, o real, de hecho. Entonces, por eso tenemos que medir el diámetro de PISA. ¿Dónde lo podemos medir? Esta es, digamos, la longitud ideal. No debe ser elíptica, debe ser más bien donde lo veamos más esférica, porque si lo hacemos más hacia arriba o más hacia abajo, se puede sobreestimar o infraestimar el radio. Y esto es una medida indirecta del orificio anatómico, más bien es el orificio anatómico que nos va a servir para medir el orificio virtual o funcional. Entonces aquí ya estamos haciendo las mediciones. Aquí también podemos medir la vena contracta, que es la parte más estrecha del jet de regurgitación. Aquí no se alcanza a apreciar muy bien, lo vamos a ver en otra imagen. Estos también son del propio paciente. Entonces ya medimos el PISA. Después del PISA, tenemos que medir la velocidad máxima del flujo regurgitante mitral. Entonces para eso ya nos alineamos con el flujo y con el Doppler continuo sacamos la velocidad máxima, que en este caso es esta, 4.16 metros. Más adelante que veamos la fórmula, lo vamos a expresar en centímetros. Entonces ya tenemos esos dos. Con esto ya podemos calcular el área con PISA. Ya tenemos el diámetro o el radio, PISA, y la velocidad. Entonces es algo muy similar que lo que hacemos con la ecuación de continuidad para el cálculo del área valvular. Ya tenemos el área determinada por el PISA, la velocidad del flujo transmitral y la velocidad del aliasing, que es esta que aparece acá, de este lado, esto. Eso nos sirve para la fórmula y despejando los valores que ya obtuvimos, vamos a ver el área del orificio efectivo regurgitante, que es un parámetro que nos va a ayudar para estimar la severidad, y es esta. Si reemplazamos los valores, es el 2 por pi por radio al cuadrado, es la fórmula de área. El radio pues es el PISA, por la velocidad de aliasing entre la velocidad del pico del flujo regurgitante mitral, de manera que nos da un área del orificio efectivo regurgitante, que es digamos, el orificio funcional de 0.49 centímetros cuadrados. Ahorita vamos a ver qué nos traduce esto. Entonces ya tenemos este parámetro. Si además queremos calcular el volumen regurgitante, también tenemos que sacar la integral tiempo-velocidad de este flujo. Y es lo que hicimos aquí. Entonces se delinea el espectro aquí del flujo transmitral y el integral de tiempo-velocidad es este que tenemos aquí, 121 centímetros. Y la fórmula para el volumen regurgitante es, una vez que ya tenemos el EROA, que es este, multiplicarlo por el ITB, que ya sacamos, y el volumen regurgitante es de 59.2. ¿Qué traduce? Bueno, les comentaba que es importante ver si es primaria o secundaria, pero en este caso consideramos que es una secundaria y los valores cortes son estos. De manera que por orificio regurgitante efectivo es severa y por el volumen regurgitante también es severa. La fracción regurgitante no la calculé, pero esta es una relación entre el volumen telediastólico y telesistólico. Si es más de 50%, también es una insuficiencia mitral severa, y pues hay diferentes parámetros. Por PISA es un parámetro cuantitativo, como lo vemos aquí. Hay parámetros cualitativos que no son muy confiables. En este caso, pues es el jet distal de regurgitación. Esta es una imagen del paciente. Si vemos el porcentaje que ocupa dentro de toda la aurícula, en este caso es aproximadamente el 40%, probablemente un poco menos, nos daría moderada a severa. Por la vena contracta le medí 0.53, pues nos daría también moderada a severa, pero les digo, estos son cualitativos. Ya uno más cuantitativo es este, y ya vimos, ¿verdad? Para severa. El volumen regurgitante, ya lo vimos también, depende si es primaria o secundaria. Para la primaria, para la secundaria, pues es esto, también es severa. Y otros parámetros que también se pueden medir, pero muchos de estos dependen del estado hemodinámico del paciente y incluso de cada latido cardíaco. Entonces, también no suelen ser muy confiables y reproducibles algunos de ellos. Pero bueno, el radio o la insuficiencia mitral estratificada por PISA, este es el método que se utiliza para valorar la severidad. Nada más.
Sí, muy bien, Ricardo. Siempre fíjense, si no tienen datos de que el paciente, por eso siempre es bueno, o sea, siempre necesitamos conocer al paciente, interrogarlo, cuánto tiempo tiene síntomas. Las causas de que una insuficiencia mitral severa no tuviera una aurícula izquierda dilatada, probablemente sea o que nos estamos equivocando o que es una insuficiencia mitral severa grave, aguda, ¿no? Entonces siempre hay que ver la cámara a la cual va a ir el volumen regurgitante y la cámara adelante, por ejemplo, también en las crónicas, la dilatación del ventrículo izquierdo, ¿no? Ok, muy bien, Ricardo. Bueno, pues entonces aquí le dejamos. Voy a avisar
Oye,
entonces al sistema. Sí, sí.
a la hora de que yo hice la medición, lo que entendí es que medí mal los anillos de isovelocidad, ¿verdad, Richie? O sea, los agarré de muy arriba. Por eso me daba el orificio más pequeño.
Es a partir del plano valvular
Ujú.
y tiene que ser esférico. Y también lo que recomiendan en el loto es que lo midas en el ciclo cardíaco, lo midas justo en el pico de velocidad del flujo regurgitante mitral.
Ah,
Entonces, que te coincida en el trazo del electrocardiograma y normalmente en ese punto, en el ciclo cardíaco, puedes medir también el PISA.
Una parte importante, Poncho, que faltó y que bueno que también, o sea, que Ricardo, es quiten el color. Una vez que identifiquen que estén en la sístole, en el punto más grande de la recurrentación, sí, quiten el color para que puedan llevar el punto desde el plano valvular. Sí, ándale, ya está quita. En una está, ahí está simultáneo, en una hay color y en el otro no. Entonces, la manera de darte una idea bien desde dónde vas a llevar el punto hacia la parte de arriba del honguito, ándale, es que tengas al lado o que hayas quitado, que hayas puesto y quitado el color, ¿no? Sí, eso te va a permitir no equivocarte tanto, Poncho.
¿Y eso lo podemos hacer así con las imágenes duales o se prefiere mejor que sea una sola imagen?
Sí, de preferencia con una sola imagen, ves el color, trazas tú dónde está la parte más alta del honguito de la isovelocidad y de ahí
Ok,
quitas el color y te vas hacia el plano valvular. ¿Sí?
ok, correcto.
¿Ok? O al revés, te pones el punto en el plano valvular y después activas el color y lo llevas hasta el punto más alto de la isovelocidad.
Ok, doctor.
¿Sí? Bueno, perfecto. Muy bien, jóvenes. Dale, pues, entonces aviso que mañana entonces, Ricardo, Eric, se conectan al de Teams para que veamos la clase que voy a dar de insuficiencia cardíaca aguda, ¿no?
Sí, doctor.
Órale,
Sí,
sale.
doctor.
Se habla con el doctor Carrillo, Poncho, si no va a ser un desbarajuste.
Sí, doctor, ahorita yo le escribo.
Órale, sale, bye, gracias.
Bye. Bye, doctor.